Facebook now, so I just wanted to welcome anyone that's in the room with us here in Click Meeting, and hello to anyone who's watching us on Facebook at the moment as well. I'd also like to welcome Dr. Andrew Kremer with us today. Thank you very much for joining us. He's joining us from Zurich today, which is amazing. Thanks very much for your time. Really do appreciate it. But before we start, I'd also just like to remind anyone that these Q&As do not take the place of a consultation with your own clinicians. We're aiming to provide general medical advice and not medical information. And also please remember that Facebook's a public forum, so just be aware of that if you're typing anything in the chat box for us here. So you can join us in the meeting room here on Click Meeting. The link was on Facebook earlier, and that's a more private environment for asking questions, but I'll keep an eye on questions that are coming in here on Facebook and also on Click Meeting as well. And we'll just make a start on the questions that have came in the week leading up to us as well, if that's okay. So first question we've got today, a wee bit of background around it, is that the patient has got chronic hives and facial swelling since December 22, which is making them, they have issues with that every day, and obviously it's super itchy. They're taking high dose of antihistamine and other medication, but it's not really having much effect for them. They've been seeing different GPs, and they've picked up that the patient is anemic, so they're also going on to see a gastro consultant as well. And they've been asked to start on URSO as their AMA positive and a high ALP. There's some more information there, Andreas, just around that they've continued on URSO for a month, but that just continued. They've just seen their GP, told to stop URSO as the bloods were back to normal, and the itching should have stopped by now. They're very confused, thinking that their GP doesn't understand PBC, and the consultant that told them to start on URSO. So it's really just a general, what should they do question. Should they be thinking about secondary therapy at this point, and what are the questions that they should be noting to ask?
Thank you very much for this kind introduction, and it's a warm welcome also from my side here from Zurich. I personally think, it's always a little bit difficult to interpret these data when autoantibodies, at least what is stated here, seem to disappear. So normally anti-mitochondrial antibodies do not disappear just spontaneously. They should remain in a disease called primary biliary cholangitis. So the constellation with an increased alkaline phosphatase and these autoantibodies clearly suggest the diagnosis. However, there are sometimes the situations that, due to some, infection or other issues, very mild titers may come up and disappear again, and then we are less much convinced that this is really a liver disease. Now, regarding itching, this is certainly a symptom of the disease. However, it's not associated with any skin alterations, which are here described. So these chronic hives and the swellings, this is definitely something when we think about chronic urticaria. And so in that regard, I think it's really necessary to consult a dermatologist and to clarify whether chronic urticaria is present. And if that is present, it's treated with antihistamines, and antihistamines should work in that regard. And we even recommend, if a regular single dose does not improve the situation, that we can titrate that up to 4 times of the daily dose. And only if this increased dosing is not efficacious, then we would switch to alternative treatments in chronic urticaria. But to summarize that a little bit, certainly this needs a more dedicated workup from a dermatologist. The anemia needs to be clarified. I fully agree. I think gastroscopy and colonoscopy would be recommended in such a regard. It depends on what type of anemia is present. And then finally, also, whether these PBC PBC is not a disease where antibodies come and go, so that should be redone, and also a full normalization after a week or so of UDCA sounds rather a little bit less likely that this is real PBC.
That's great. Thank you so much. I know there was quite a lot in that question, so I appreciate you taking the time for that one. So moving on to our next question, it's around a FibroScan. So the FibroScan score had went from 9.7 to 4.6 in 2 years. And there was a worry that the higher score were being deleted because they weren't matching up with the blood work. They'd moved the probe round about to get lower readings, and the patient's been really uncomfortable with these readings and told to go back for an ultrasound next year. Is it possible that these readings could change in that amount in the 2 years? Is that possible?
Well, I personally think it is possible because, in particular, initially, if PBC is untreated, we commonly have increased values measuring elastography, so liver stiffness, due to the inflammatory component and the cholestasis, which is there aside a potential liver fibrosis. And the treatment with UDCA improves not only cholestasis, but also inflammation. And if you take out the inflammation and improve the inflammatory component, then you have less of an organ swelling, you have reduced stiffness, and this then can very well result in improved stiffness measurements as illustrated here in this case. And so I think this is well possible, and it has to be kept in mind that the initial values do not necessarily represent fibrosis, but rather inflammation, which is improved. And this is then now in a normal range, the elastography, and this is a very good sign. And I would definitely think that this is a good signal, a good result. And in particular, if the cholestasis parameters are improved as well, then I would strongly recommend to continue the treatment and to interpret that as a very positive result.
Okay. Just note at the end of the questionnaire, the patient had been noted that there would be no need for an ultrasound the next year. Do you think that's appropriate considering the score of it, or would it be appropriate for her to ask for another ultrasound in a year?
No, I think I think personally we do that once annually if a patient is non-cirrhotic. Annually, sonography examinations, including elastography, is absolutely sufficient. No need to increase the number or the frequency of these examinations.
That's great, thank you. So moving on to the next question, the background is the patient's waiting for a formal diagnosis of PBC, but the consultant thinks it's very likely. They have a lot of joint pain, but so far the consultant has not treated for. Can we provide any information on the treatment for joint pain?
Well, I mean, the diagnosis of PBC is, very simple. In most cases, an increased alkaline phosphatase in combination with the typical autoantibodies, the antimitochondrial antibodies, or the subtype antimitochondrial antibodies M2, AMA M2, or alternatively, PBC-specific anti-nuclear antibodies. They are also entitled SP100 or GP210 antibodies. Once this combination is present, so the cholestasis pattern with an increased alkaline phosphatase with the one or other or the combination of both antibodies, that makes the diagnosis. And that's very clear and it's very specific. And if that is present, there is no reason to wait, for a treatment, because the UDCA, the ursodeoxycholic acid treatment, that's an endogenous bile acid we all have in our bloodstream, and we just enrich the bile acid pool for this hydrophobic, more protective bile acid. And in that regard, I personally think, there's no reason to wait any longer, and the prescription can even be made, without seeing a patient once again, with, to start that. I personally would titrate in a little bit this medication. I would not start with the full dose. I would, first start with 50% of the final dose and then increase it after 2 weeks to the full dose. In the morning, 1 dose, in the evening, 1 dose, normally 13 to 15 milligram per kilogram body weight are necessary. So that means approximately if your body weight is roughly 70 to 75 kilograms, then you require 1,000 milligram as an ideal amount of this medication. And then this would mean that you start with 500 milligrams in the morning, and after 2 weeks, we normally increase the dose to 500 milligram in the evening. In that regard, I would, just try to call this consultant again and say why he's, hesitating to send you a prescription. You would like to start this treatment, and hopefully then also your symptom burden will improve under this treatment. If not, then you should definitely consult after 3 months a rheumatologist, because there could be other causes for joint problem, such as a rheumatoid arthritis, which could be there aside the liver disease. But commonly the joint pain is associated with this liver disease. This is not so uncommon. We even have patients referred by the rheumatologist who tells us this is not a rheumatological disorder, but the typical autoantibody constellation then hints towards a liver disease. And when the liver disease is treated, that should also ideally improve.
That's great, thank you. So moving on to the next question, we've got, can we give any information on the importance of vitamin K2 to take alongside vitamin D, as many patients with PBC are vitamin D deficient?
Yeah, there is, always the idea that vitamin D is improved in its efficacy once there is vitamin K. I personally think this is the case, but you have to imagine that vitamin K is produced by the intestinal microbiome, and normally that works very well. There is not a need to supplement that because it's just present in full amounts, and normally it's also adequately absorbed. You must be very jaundiced, or the enterohepatic circulation is somehow interrupted, that this doesn't work anymore very well. So in most cases, personally, I think it's not necessary to supplement vitamin K along with vitamin D. These are a few cases where this is required. And then in most cases, I think intravenous supplementation is the best, because if the oral uptake is not sufficient, then the oral supplementation doesn't help so much. So in that regard, in most cases, I think this is not really necessary, but vitamin D is produced by, 3 body parts. The first part is the skin in combination with UVB light. So you need the UV light to, break off the circular structure of cholesterol. And then the second part is made by the liver. And the third part is made by the kidney. And if the liver is sick, it does not produce anymore as sufficient this vitamin D precursor, which is called 25-hydroxycholecalciferol. And in that regard, it makes sense, even if we have sufficient sunlight, if we have sufficient exposure to the UV light outside, that this is not enough, because the liver doesn't adequately performs the second step. And in that regard, it makes sense to supplement then this vitamin D, isoform, which is only activated later on by the kidney. And so I think this is, worthwhile supplementing, while the vitamin K supplementation is not per se necessary. And it has to be kept in mind, the biological active vitamin D is only made within the body after it is metabolized by the kidney. So with this supplementation, we take up an inactive precursor.
Great, thank you. Another question is just around patients with PBC, as their immune system is a bit haywire, is the term they've used. Does it mean that you may react more to general viruses, for example, colds, chickenpox, etc., or will you react the same as anyone else? So because PBC patients have an autoimmune condition, does that mean that they're a bit more likely to pick up other infections?
Well, you know, I personally think that the immune system per se is not really influenced in PBC. The influence is altered in that regard, that it somehow recognizes small biliary epithelial cells, so the cholangiocytes, the cells forming the bile duct system, that they are attacked by the immune system. They are regarded as foreign somehow. We have not fully understood why this is the case. But that doesn't mean that it reacts less well to other exogenous factors such as bacteria or viruses. And we normally don't see an increased risk of infections, despite the fact that there is a statistical higher rate of urogenital tract infections. Why this is the case, this is not purely well understood, and whether this is a cause or a consequence is also not very clear. But otherwise, the immune system is not really altered. I personally always think that vitamin D is important for the immune system, and that too low vitamin D levels, which are commonly seen in PBC patients, are a potential factor which could be responsible if there are repetitive infections. So I would check for the vitamin D level in the bloodstream. But otherwise, we do not treat the typical PBC with immunosuppressive drugs such as steroids or other immunosuppressive drugs. And UDCA has not a negative impact on the immune system, neither do second-line therapies. So in that regard, if there is not an autoimmune hepatitis component which is treated by immunosuppressive drugs, then the immune system should not really be altered. And I don't foresee any limitations in that regard.
That's great, thank you. We have another patient who has had some regular nosebleeds and once a hemorrhage, which had sent them to the ER. Is this common with, they've got PBC and cirrhosis?
If PBC has led to the development of liver cirrhosis, and in particular with liver cirrhosis and portal hypertension, meaning that the blood from the gut, which is filtered within the liver, is not running smoothly through the liver again, then this can result in an increased size of the spleen. And the spleen is then like a huge parking house, a huge garage for platelets. And then the platelet count can go down. And if that is the case, then you may have a higher risk for bleeding, as the platelets are important for the first step of coagulation, for the initiation. And then, nose bleeding can be associated with PBC, but only in the real advanced disease stages. In early disease stages, this is not the case. If this is a pre-cirrhotic stage, I would definitely, perform further checkups if this is repetitively a problem, because then it is well possible that another underlying cause is present in this person, and it has to be established why this is the case.
That's great, thank you. The patient did mention that they had cirrhosis. So.
Yeah, in that regard, then it's most likely a sign that this is advanced disease stage. And then it is, in my point, important also to be referred to a transplant center where they have experience, or the largest experience with these advanced disease stages, and what to optimize in such a situations. A lot of optimization can still be done in this advanced disease stages, but this is important to be really at a transplant center. Or expert hepatology center.
That's great, thank you. The next patient as well mentions that they have cirrhosis caused by PBC and they have ascites, which is controlled by water pills. They're asking if they urinate more if you're retaining fluid, or is it the same for everyone? So the question is, do you urinate more if you're retaining fluid, or is it just the same for everyone?
In principle, if we have ascites, we only have a higher amount of fluid within the body. And in that regard, it's not in the bloodstream, it's not in the tissue, it's in the abdomen, in the belly. And once we take diuretics, then this fluid is mobilized, and more fluid is then secreted via the kidney. And so we have the impression that once we take these diuretics, we have to go more often on the toilet. However, this is only as long as we recompensate the situation. So once the ascites is treated adequately, and this does not mean that ascites has to be not present at all anymore. We would accept a little bit of ascites in the abdomen. This is not a problem, but too large amounts are not optimal. So this needs to be treated. And once we stabilize that again, once we have weighed that out again, then we do not urinate more. It's more like the amount of fluid we have as an oral intake. So that shouldn't be too high. If we always recommend 1.5 liters per day, that is the upper limit of oral fluid intake, which should not be exceeded too much, because once you drink more, you have to somehow get rid of that water again. And if the liver function is not optimal, then we tend to have more ascites. And in that regard, it's not only necessary to get the fluid out by diuretics, but also to limit a little bit the oral fluid intake.
Thank you. So background to the next question is, patient had a transplant 8 years ago and they've been told that the PBC has come back. Still taking urso, but when they've asked if it's right that the PBC is coming back, the doctors don't seem to know, which seems very odd. So I don't know if the patient doesn't know if they still have it or not. So I'm just reviewing that question again, just to be clear on the question there, Andreas. So it's the patient's been told that the PBC has come back and still to take urso, but there just seems to be a wee bit of confusion over that. So it's just some advice on that and any further questions that they could ask of their healthcare provider.
Yeah, I mean, that's a very, very good question. And actually, there is very limited data on that. We really have to admit that our knowledge on recurring, relapsing PBC in a transplant organ, that our knowledge is very much limited. We have well understood that UDCA therapy after liver transplantation reduces the risk for this relapsing PBC. Now, I personally think the important aspect here is to look on the lab values. And it should always be the aim that the liver tests should be normal. So the aim would be that the treatment, the UDCA, the URSO treatment, in combination with the immunosuppression, that this results in normal blood tests. And if I apologize, the background noise. So in that regard, if that is not the case, I would personally look at the alkaline phosphatase. And if the alkaline phosphatase is more than 1.5 upper limit of normal, so normally, at least for the German or the Swiss cutoff for a female person, it's 105. So let's presume it's more than 160 units per liter. If 105 is the cutoff in the UK or where you are, then I would consider a second line therapy, as we do that in a pre-transplant patient. And in that regard, there are again several options. because we have several components which can be given to patient. And obeticholic acid is, of course, the licensed drug. It's well tolerated even in transplanted patients. It's hardly given because even the treating physicians do not often think about that. So if I were you, I would go to my treating hepatologist or gastroenterologist, in particular the one who is at the transplant center, and tell him, look, I take UDCA. I've been transplanted for PBC. My alkaline phosphatase is rising. It goes up. It's more than 1.5 upper limit normals. So I've heard that in those cases, even if they are rare, a second-line therapy should be considered. And in that regard, it may be necessary to ask the insurance company to, approve that, also in this situation, a second-line therapy is worthwhile. But I think it's a very safe drug treatment, and we do that. Alternatively, if obeticholic acid for any reasons is not available in your country or the insurance company doesn't pay it, an off-label therapy with bezafibrate could be done. If you're in the US, it's difficult because it's not available, but in many other countries it is available. And if you have no kidney problems, so if the kidney function is fine, I consider bezafibrate in most cases as a very safe drug as well. You take 400 milligrams per day, and if you suffer from pruritus, you may have the benefit that also pruritus could be improved. Alternatives could be fenofibrate, if bezafibrate is, for example, not available. These two drugs are very old drugs, but they are very cheap. Could also be if you're in Asia or in Eastern European countries where the labeled drugs are not available. That could be an option. And the third option could then still be budesonide. This is a steroid which is metabolized by a high pathway in the liver. So it acts in the gut and in the liver, but not in the periphery. And it has been shown that budesonide is also of benefit in PBC, despite the fact that a clinical trial had a negative result, because the negative result was based on histological improvement, which was not achieved, but cholestasis parameters went down quite well. And that could be also an alternative, in particular, if you take some steroids, a little bit of steroids. I would, for example, consider to replace the systemic steroids, such as prednisolone. If you take 2.55 milligram, then by budesonide, that could be also an option in such a case. So 3 options which are potentially available. Discuss it with your treating hepatologist, and reconsider us if you are not successful.
Just following on from that, obviously the AMA positive, if you're pre-transplant, when you're diagnosed with PBC, you're AMA positive. Does that remain positive post-transplant?
Yeah, that's a good question. Indeed, this is the case. These autoantibodies do not disappear. That is typical. But on the other hand, this doesn't mean that this autoantibody results in recurring PBC, because these antibodies will remain in all PBC patients. And only, luckily, a minority of PBC patients have this recurrent PBC. So we need more than these autoantibodies to induce this disease. But indeed, the autoantibodies, they stay there. They will be lifelong present in a PBC patient, even under immunosuppression and so on.
No, that's great. So I'm just going to move on to the last question that we've been sent in for this week, but we do have a few questions coming in on Facebook as well, which is great. So the last question that we have on the list for this week is a patient who's been on Arzo for just over 3 months after being diagnosed. They're currently changing, their GP has limited knowledge, and they're currently changing hospitals, so they're not under a consultant at the moment. What they're finding is that they're having significant hair loss. They already had quite fine hair, and now they're quite concerned that they're going to lose their hair completely. They also have Graves' disease, and they've reached out to their consultant regarding taking some supplements if they're able to do that. So the question, there's 2 parts to the question. Is it normal for PBC patients to suffer hair loss? or for it to slow down? Will it grow back? And is it safe for the patient to take supplements to help with it?
Yeah, that's a very important symptom here, hair loss. There is no association with hair loss and PBC, but there is clear association with thyroid dysfunction. So I personally would consider Graves' disease as the cause of the thin hair, of hair loss. And this needs to be optimally treated. And if optimally treated, then the hair should grow back. And you should, in the best case, have, the hair as you have had it before, because the, the thyroid dysfunction, if it's restored, if you have a regular hormonal level, then this should, also be fine for your hair follicle. The hair follicle are normally not destroyed by a thyroid dysfunction. They may only be destroyed by strong chemotherapy or radiation, but not by a thyroid dysfunction. Normally, hair should regrow once this is restored. And so I would not consider UDCA therapy or the underlying liver disease as a problem here. I think UDCA should be given to PBC lifelong, and you latest after 6 months, you should look to which extent my lab values, my cholestasis parameters, the alkaline phosphatase, bilirubin, to which extent has this improved, and if that is coming towards only mild elevated levels, then I think the treatment response is good. But after 6 months, we can estimate roughly whether this is sufficient or not. If alkaline phosphatase is still very high, 2 times, 3 times, 4 times upper limit of normal, then you should already at 6 months consider whether you require a second line therapy. So after another 3 months, the blood control, you can have a look, and if the LP is, let's say, below 2.2 times upper limit of normal, then you're on a very good track, I think. This will further improve, of course, but if you're above, the likelihood that you achieve a good response after 12 months is less likely, and you should ask your treating gastroenterologist or hepatologist maybe to start early for second line therapies. There are novel data out there which have been published.
That's great, thank you. One other question actually that's been sent in just before I move to the Facebook questions. It was one that came in later. So we've got a patient on a lower dose than the recommended 200 milligrams fenofibrate, and they're suffering from regular UTIs. We've read that there's a link between the two. Any advice on that?
What was the symptom burden? I didn't.
Regular UTIs, urinary infections.
Urinary tract infections, yeah. Normally, fenofibrate does not cause urinary tract infection. It is, as for bezafibrate, not ideal to take this drug if the kidney function is not optimal. So kidney function should be normal, and if relapsing urethritis is a problem, then kidney function may also be potentially worsened or suboptimal. Then fenofibrates in general are not ideal. In that regard, I think it is very important to stop that drug if the kidney function is, in particular, latest below 45 ml per minute, the glomerular filtration rate. If kidney function is normal, then I would definitely go to a urologist or a gynecologist, look what kind of bacteria are there, is it fungus, what are the causes of that, because that is very much important. PBC is associated more commonly with these urinary tract infections. We don't know whether this is cause or a consequence. I rather think that this is, not a consequence of PBC. It's rather the other way around. If you have these infections more often, you may have a higher risk to develop PBC, and this needs to be treated. There are good long-term treatments for relaxing urethritis. There is D-mannose, for example. It's a certain special sugar which is not metabolized in the body. It goes into the urine, and that can be given on a very longitudinal way to reduce the number of these urinary tract infections. That is, for example, something once with an antibiotic treatment, urethritis is treated as a long-term drug addition in these female patients. And of course, an additional point is we have to exclude diabetes, because if too much glucose levels are in our bloodstream in untreated diabetes, then we excrete glucose into the urine, and this results then in a higher risk of infection. So this should be definitely also excluded.
Okay, thank you for that. So I'm just going to pick up, just to anyone that's in the room with us in Quick Meeting here, if you have any questions for us, if you pop it in the chat, I'm just going to pick up a couple of live questions that we've had on Facebook. So one of the questions we've had from a patient on Facebook is there anything you can recommend to help with fatigue for patients with PBC and compensated cirrhosis?
Yeah, fatigue, the brain fog, however it's entitled by people with PBC, has two components. I think there is a central part and a peripheral part. And the peripheral part is that you are more quickly exhausted, you have less muscle energy. In that regard, I personally think regular movements, some kind of mild trainings are very helpful on a very regular basis. Of course, you feel not energetic, but still, the repetitive muscle strength helps in that regard. I prescribe coenzyme Q10 because this is a electron transporter within the mitochondria, and we have a mitochondrial problem in our patients. So in that regard, I like this supplementation. We need much higher amounts than that what is commonly recommended, 2 to 10 milligram per kilogram body weight. 2 to 10 milligram per kilogram body weight is important here per day. So 100 milligram would rather be the lower end, and higher oral uptakes could be useful. And on the other hand, we should exclude any other causes, cardiac dysfunction, anemia, hypothyroidism, so thyroid function is important, depression, celiac disease, other autoimmune diseases, autoimmune hepatitis. So we should optimize what is optimizable, but otherwise we have no real causal treatment here. For the future, we hope that clinical trials will arise to treat the symptom, but otherwise I think it's very important to accept this symptom as part of the disease, to stratify a little bit the daily activities to do. In the morning, the fatigue is the best to do those things where you have to be mentally fit in the morning, in the first part of the day, and then rather other things later on in the day. So structural optimization of the daily life activities, that's not very easy, and requires a lot of changes. I fully agree, but these are recommendations which may be of benefit. And if severe pruritus is a problem, night pruritus is disrupting sleep, that also can be treated, and then fatigue may be improved.
We have a patient who has neuropathy as a problem that they suffer from, no pain, just intense numbness. Can you talk about the connection with PBC and any tips for relief? They do exercise at the moment, they've tried acupuncture, keep a good diet, etc. They have been offered gabapentin, but don't want to take that just at the moment. So just if there was anything else that you could offer advice on around that.
Yeah, I think the anticonvulsive drugs are quite good in that regard, and they are licensed to treat neuropathic pain. I think these symptoms are, you know, often a disbalance in the sensory neuronal system. And if gabapentin is not sufficient, it may depend on the dosing. We have, if the kidney function is normal, we have a very large therapeutical range of this drug. We can start with 100 milligram and it ends at 3,600 milligram for gabapentin. For pregabalin, it's 25 to 600 milligrams. So we have a huge therapeutic range. And to see the full effect, we really have to titrate this drug up. It needs to be taken at least for 6 to 8 weeks to have a full mode of action. And in that regard, I think it's very important to look at the dosing. And if tolerability is there, I would really try to titrate that up. And until we see the benefits really start from what is published on neuropathic pain, from 50% of the maximum dose for gabapentin, that would be 1,800 milligrams, and up to 2,400, 3,600 milligrams. So that should be given. And if that really still doesn't help, then a switch to pregabalin can be taken. Physiotherapy could be added. That would be my first recommendations, and really treat it for at least 6 weeks before you stop that treatment.
Thank you. And another question is actually following on from what you'd mentioned in the previous question around itch. So itch is the patient's main symptoms. Awful. They're on Lyrica, Lyrica for it just now, and also had plasmapheresis, but it gave very little relief. Just asking if we could discuss itch and what the treatments are.
And plasmapheresis for what symptom? I didn't
for
get
itch.
that. For itch.
Yeah.
Yeah, this can be done. I only consider plasmapheresis in really therapy refractory cases where really we have tried all kind of combinations, topical treatment, maybe even UVB therapy, combination therapies, rifampicin, fibrates, sertraline, doxepin, mirtazapine, and so on. The gabapentin, pregabalin can be helpful for an itch as well. So if that is really exhausted, if we don't have a benefit and there is still a lot of suffering from pruritus, then plasmapheresis can be very helpful. It can have, in particular, a long-lasting effect for months, for many months, even in cirrhotic patients. So in that regard, I would consider this as an option before we consider, in particular, liver transplantation in the absence of advanced disease stages or liver failure. So yes, we do that as well. Specialized centers will offer that, and you may have to ask which center has experience with that and performs these interventions. They are quite costly. You need a huge intravenous catheter to perform this plasmapheresis. This is associated with some risk. It's not very risky, but it can be very helpful and in particular cause a long-lasting effect. So in that regard, if everything else is not of success, then this is an option.
The patient said they have tried plasmapheresis, but it gave them very little relief.
It didn't improve the relief.
How often would you recommend for the number of treatments for plasmapheresis?
Yeah, we would. I don't know how many. Normally you do that at least 3 days in a row, plasmapheresis. So I don't know to which extent that has been done. And if that is not the case, it still needs to be always questioned whether then this is really PBC itch or if any other cause of itch could be also present. Theoretically, a lot of other causes are out there, from dermatological disorders to other systemic disorders to drug adverse events. If a full 3-day plasmapheresis course is not efficacious, I would think that I would not repeat it. I would then think, one may try an albumin dialysis, molecular absorbance recirculating system, Prometheus or whatever. That could be an alternative intervention in therapy refractory cases.
That's great, thank you. That's all the questions we've got on Facebook at the moment. I'm just seeing that we've got a couple of questions here in the room. I'm also aware that you need to finish up at 10 to Andreas, so I'm just keeping an eye on that. There was a question, it just follows up on what we were talking about earlier about the vitamin D. So one of the questions is, what dose of vitamin D should be taken each day?
Well, I personally think that depends on the levels. So we normally perform vitamin D level quantification in the bloodstream. And if that's normal, then you have sufficient vitamin D supplementation. Normal, if you have low normal levels, I would still consider to take a little bit. You have to imagine that if we talk about nanogram per ml, that 1,000 international units of vitamin D increase your level by 10 nanogram. So if you have a level in the bloodstream of 20, you take 1,000 units, you will rise this level to 30. I would think 30 should be the lower level. 40 is better. I think 40 to 50 would be a good aim. And if your levels are, let's say, 10, and then you want to go or to achieve this level, then I would think that 4,000 international units per day would be the amount you would have to take to reach that aim. And this needs to be controlled after 6 months, whether this is then sufficient or not.
Okay, that's lovely. Do we have time for one more? Can I sneak one more in?
Yeah, a very quick one.
We have one in the room here. Could a flare-up in a PBC AIH patient be the result of a Hep B holiday vaccine or a COVID vaccine? So a patient with PBC overlapping AIH has had a flare-up. Could that be due to a Hep B or a COVID vaccine?
Yeah, I mean, in principle, we know that any kind of infection can cause a flare of autoimmune hepatitis, less likely of PBC, but of autoimmune hepatitis, this is more commonly seen. It can also be, we see flares or let's say inflammatory signs if a healthy liver experience or a person with a healthy liver has an infection, then transaminases can rise. And the same holds true if we perform a vaccination because it activates the immune system and this may cause a flare. So this flare should come down again relatively quickly. If that is not the case, then treatment of PBC and or autoimmune hepatitis should be reconsidered or shortly increased to calm down again the inflammatory process. But yes, that is possible.
That's great. That's us. Thank you so much for your time today. We really do appreciate it. We've answered most of the questions that have come in either to us in advance of the session and also on Facebook and in the room here in Quick Meeting as well. So thank you so much for your time. We really appreciate it. And thanks to everyone who's joined us in the room here and on Facebook as well.
Wonderful. It was a big pleasure and a lovely day to the whole audience, and see you soon. Thank you.
Thank you. Take care. Bye-bye.
Take care. Bye-bye.